It's going to be life-changing. With the type of information that we're going to be able to get from a single biopsy, I think arguably in the future, it could be irresponsible to conceive without knowing what's in your hand before you play it, so to speak.
Today we have Dr. Barry Behr. He's an internationally renowned clinical and scientific leader in the research and advances of human reproduction. He's a board-certified embryology lab director and most recently was a professor of obstetrics and gynecology, reproductive endocrinology, and fertility at Stanford, as well as their IVF lab director. Thank you so much for joining us.
Thanks, Nora. Happy to be here.
Great. Okay, cool. So we really have to start with just the most basic things. Can you just start by giving just a quick overview of when can people get pregnant? Forget about IVF, forget about embryology, just how does it work the old-fashioned way?
Well, you're asking me the birds and the bees talk,
Yes.
basically. But people can get pregnant when there's a presence of an egg and the presence of the sperm in the human body, usually in the reproductive tract somewhere, so that they can unite, form an embryo, and implant in the uterus. It can happen as early as a young girl starting her menstruation in her early teens through typically the mid-40s at the latest. Obviously, there are exceptions to every situation, but that's the typical age for a woman to be able to get pregnant. And for a man, really, as soon as he reaches puberty, which is also in your teen years, essentially until he stops having a heartbeat. It's thought that men can really contribute to a pregnancy. As long as you're alive, making heartbeats, you're still probably making sperm in some way.
Could you talk a little bit about the embryology side? Basically, I think something that a lot of people don't know is that when people are forming as embryos, that actually their gametes are some of the things that form first, right? Before their brain, before their lungs, before all these other organs, their gametes form first. Can you talk a little bit about that, about how gametes form in an embryo and how is that different between men and women?
Yeah, no, it's really fascinating how gametes form and where they form relative to where they end up. The gametes make a huge migration during early embryology to ultimately reside in an area that's called the genital ridge. And this area of the anatomy is, for a certain period of time, undifferentiated, meaning that there's not much difference between male and female or X and XY embryos. But as embryology proceeds, as development proceeds, these germ cells differentiate, the organs in which they reside differentiate, and this is all through genetic programming because the XX and the XY chromosomes really determine the direction in which these initially undifferentiated gonads will diverge to become male and female genitalia, which house the sperm cells and the future sperm cells and the future egg cells. What's very interesting is that eggs go through a developmental pathway that really is on a finite mission. A woman is born, a girl embryo, a girl fetus is born with all the eggs she's ever going to have. In fact, from the minute she's born, or from the minute really they are deposited in the genital ridge, they go through a huge attrition by millions over the time of gestation and by the time a woman reaches puberty to start menstruation and now actually ovulating these eggs. Whereas a man's XY path of differentiation really results in a self-renewing population of these future sperm cells that essentially allows men or XY gonads to make sperm perpetually. There is no finite system of a particular number of primordial germ cells that will be deposited and become eggs. For that reason, I mentioned earlier that men essentially, in theory, can produce sperm from this renewable source of sperm cells to become primordial germ cells, that is, to become sperm as long as a man's healthy enough, and I mentioned before, essentially having a heartbeat to be alive.
Yeah. So yeah, that's super interesting. So basically, a baby girl has more eggs, more viable eggs than actually a 20-year-old or 25-year-old woman because your eggs are just constantly being
Yeah.
depleted over time.
Correct. It's thought that a woman loses about 1,000 eggs a month.
Wow. That's crazy. And does that actually it decreases as you get older? Like, so toddlers are losing more eggs than teenagers or
Well, I'm not an egg decline expert, but what I've
yeah.
learned and studied is that there's a pretty constant decline of about 1,000 eggs a month. Even when you are not ovulating anything, you're still losing 1,000 eggs a month. Even when you get 20 eggs from an egg retrieval, you're still losing 1,000. You may be losing 980 eggs that month because you were able to retrieve 20. But
Yeah, yeah, yeah.
constant decline until it's thought that a woman runs out of eggs in her mid-40s, which is about the time that, or the average time that women begin the more serious effects of menopause when they run out of eggs.
Yeah, so just in terms of the, genetics, do you wanna talk a little bit about basically how DNA degrades or changes in eggs over time and how DNA changes and degrades in sperm as well? How does it
Sure.
what are the similarities? What are the differences?
Sure. You know, one of the advantages that sperm have is that they're always young because
Mhm.
they are being manufactured throughout a man's life. The disadvantage an egg has is that an egg has been laid down prior to birth and it's been sitting in the person's body till it is ovulated or fertilized, hopefully, and hopefully makes an embryo and implants. The problem with that system is that the genetics of the egg are as old as the individual, not like
Mhm.
sperm, always a few months young. So
Mhm.
the eggs that ovulate in an older woman have more fragile DNA and potentially more genetic defects than eggs that ovulate in a younger woman, relatively younger woman. And it is thought that the best eggs are ovulated when you're younger, and the worst eggs are remaining as you get older. And therefore, the eggs that you ovulate as an older woman have demonstrated higher genetic infidelity. Therefore, there are more genetic errors, less ability to correct these errors, resulting in embryos that have, or eggs and embryos that have higher chromosomal anomalies or abnormalities than eggs from, or eggs from embryos, or embryos from eggs, excuse me, from younger women who would have a better machinery to correct any abnormalities and a lower baseline aneuploidy rate than an older woman, if that makes sense.
Got it. So sperm also accumulates mutations linearly over time versus eggs, they have a little bit more of a nonlinear trajectory. Like at a certain age, the mid 30s, you see a much higher rate of aneuploidy. Do you want to talk a little bit about that?
I think it's just basically related to the age of the machinery in the egg.
Mhm.
The sperm will have a constant rate of decay because the huge variable of age essentially eliminated in sperm production. The eggs in a woman's body are going to be exposed to any environmental stress or toxin that she may expose herself to intentionally or unintentionally. Therefore, the accumulation of adverse environmental conditions inside the body could have a dramatic effect on the ploidy, the genetic normalcy status of the egg because of its potentially altered environment in a negative way. You know, you would expect sperm's DNA to degrade at a constant rate because it's always being replenished. And the risk with sperm aneuploidy may be related to the fact that it's reproducing so much that there could be a replication error or something like that, versus eggs that are sitting essentially in meiotic arrest until they're activated.
Yeah. So can you talk a little bit about sperm freezing and egg freezing? Should everyone do it at 15? Now it sounds really scary. What happens when you freeze eggs and sperm? How do you unfreeze them?
Sperm freezing has been around, or semen freezing has been around for over 100 years. The idea of preserving sperm is not new. There have been techniques that have evolved that are, to be quite honest, marginally different from the early attempts, using cryoprotectants to help maintain the sperm's viability through the transition from a liquid seminal plasma to a frozen, a solid pellet that then gets warmed up and sort of reconstituted, so to speak. So it's relatively easy. The techniques are relatively simple to preserve sperm through these various states I just described. Eggs, on the other hand, have not been frozen for very long. Really successful egg freezing has really only been around for maybe 10, 15 years.
Mm.
Although the first successful frozen egg story was in the mid 80s, we really have not been able to do this well until the late 2000s. Egg freezing is a technically challenging process. It's much more fragile than sperm freezing. You're dealing with far fewer cells that are harder to put viably through this transition. And fortunately, the most recent iteration of egg preservation is vitrification, which has proven to be the most viable alternative we have. It is very successful. Fresh is still better than frozen on anything, but vitrification of eggs was a huge breakthrough that's allowed us to give women options to delay childbearing that we never had before, and other options that we didn't have on our sort of menu before, since we're able now to essentially viably preserve eggs routinely.
So when you freeze and unfreeze eggs, how many do you lose?
We are much more efficient with egg freezing than we are with sperm freezing.
Oh, really?
Yes, when we freeze eggs, we recover 95+% of what we freeze. The survival
Wow.
rate is very high. With sperm
Mm.
freezing, on the other hand, we lose about 50% of the sperm.
Wow.
But again, when you're dealing with, if you've got 20 million sperm and you lose 50%, you still have 10 million sperm. You
Yeah.
have 10 million sperm and you lose 50%, you still have 5 million sperm. We're not dealing with millions, we're dealing with a handful of eggs. So in
Mhm.
order to have a viable, clinically useful technology, it has to be that efficient.
How does that compare to embryos? When you freeze embryos, how many are you able to unfreeze?
Well, it's about the same.
Hmm.
To make that a little more accurate, I would say eggs are 90% and embryos are 97%.
Mm.
So
So why is there a difference?
embryos are multicellular.
Hmm.
You can afford a cell or two to be damaged on an embryo and still have a viable embryo.
Hmm.
An egg has one cell. If
Hmm.
that cell is damaged, it has a far greater impact on the viability of that cell, that egg, than an embryo that has 100 cells. A blastocyst may have 100 cells. So you can afford to lose one or two when you have 100. You can't afford to lose one or two when you have one.
Got it. And then in terms of sperm freezing, how many vials of sperm is it to fertilize how many embryos?
It's really how many sperm are in the vial, to be quite honest. But on a normal man,
Yeah.
one vial of semen has enough
Hmm.
sperm to fertilize as many eggs as he could be challenged with. As I said, there are millions of sperm typically versus a handful of eggs. So one sperm vial, if it was reused or divided up, could be enough for multiple attempts of IVF. Now, we don't recommend that because
Hmm.
we don't want to have our back against the wall, but typically on a normal male, there is sufficient sperm from one ejaculate to
Hmm.
achieve multiple IVF cycles.
Yeah. Can you talk a little bit about sperm sorting? Is there a way to tell which sperm has an X chromosome and which one's carrying a Y, which one's going to make it? Because obviously, sperm determine whether it's going to be a boy or a girl. Is there anything that you can talk about there?
Sperm sorting is the breakthrough waiting to happen in our field for sex selection. There
Hmm.
is no successful proven method that's clinically available to sort X and Y bearing sperm in humans today. There have been approaches using flow cytometry that have worked. There have been approaches using differential density centrifugation that have not worked. And right now, the best way to select the sex of an embryo is essentially sex the embryo, not the sperm. Clearly, it would be much easier to sort sperm, and it's done in domestic animals like cows, for example, quite effectively. It just doesn't work in human sperm. And unfortunately, as I mentioned, there is no FDA approved way to do that today.
Got it. Okay. Can you take us behind the curtain of the embryology lab? What happens there? How does it work? How are embryos made?
The embryology lab is the most amazing room that you can ever go into, in my opinion. It certainly changed my
Hmm.
life and my trajectory in careers when I witnessed an embryology lab in the mid 80s, so very early in the US world of IVF. So labs were not as sophisticated as they are now. But it's really an area, a room where life is created. It's a room that has limited access due to its high value cargo, due to its exquisite conditions that need to be maintained to allow this process to continue effectively and efficiently, and due to the equipment and conditions, settings, and things that are at high risk of changing that could affect things in a negative way. So it's essentially a room that has microscopes, incubators, a lot of other medical equipment like centrifuges and water baths and pH meters and liquid nitrogen tanks, gas fittings, water bottles, gas bubblers, filters, syringes, petri dishes in a very controlled air environment. So the temperature and the particle count is very strictly controlled. We wear special clothes, we wear scrubs, we wear very much like you wear in an operating room.
Yeah. So could you give us sort of the play by play from when the eggs get retrieved? What happens? How many days does it take? How many people are involved? How many petri dishes? Just kind of walk us through the story.
Sure. After about 12 to 14 days of shots and ultrasounds and blood tests, a woman is ultimately ready to have her eggs retrieved. And this is determined by a variety of interrogations to pick the apple at the perfect ripe stage, i.e., go into the follicles and retrieve the eggs at the perfectly ripe time. An average of 10 to 15 eggs are retrieved from a woman, of which 80% are mature, i.e., are ripe. So not every egg that is harvested from a woman is usable, but the majority are. Once the eggs are retrieved, the eggs are delivered to the laboratory in a test tube that is filled with follicular fluid. So the egg floats in a follicle in the woman's ovary, and the reproductive endocrinologist doesn't suck the egg out. They empty the follicle. It's like popping a blister, and empty the fluid, and hopefully the egg comes along with it. The embryologist then looks through that fluid to find the egg and collects all the egg from the tubes that come. This is where test tube baby comes from, by the way. It's the only place an egg sees a test tube is when it's retrieved.
So how are those eggs collected?
So the fluid is poured out it's aliquoted into several petri dishes, and the petri dishes are scanned physically under the microscope by a trained embryologist to identify them. And once the eggs are identified in the follicular fluid, a pasture pipette, which is like a very finely controlled eyedropper, if you will, is used to pick up the egg in the fluid and collect it in culture medium that is being kept at body temperature, at the right acid-base balance, at the right humidity during the egg retrieval procedure.
Is there a difference between embryologists in terms of if you get them out faster, do more eggs survive? If they get them out slower, do fewer survive?
Well,
Or is it they're pretty strong, they can handle anything?
a good embryology lab has conditions to help maintain body temperature throughout the retrieval process and the identification process. You definitely have some wiggle room. Rushing and trying to be too quick is not good. Leaving your eggs out while you go have lunch obviously is unacceptable. But you have wiggle room to take your time to identify the eggs. We have heated surfaces, we have gas bubblers, we have things that maintain the conditions while we find the eggs. Of course, being efficient, being able to be fast and effective is better than being slow, but qualified trained embryologists do it in an appropriate amount of time that should not negatively affect the viability of the eggs.
Great. Okay, cool. So we have our eggs. They're in the culture media.
So we have all our eggs on one basket now. And while the eggs are being collected and evaluated, a sperm sample essentially is being produced or is being received by the lab so that the sperm processing for the specific type of insemination can commence. We do not typically inseminate or do intracytoplasmic sperm injection, which I'll explain in a minute, sooner than 2 hours after collection. So we only inseminate eggs or inject them between 2 to 6 hours after collection. And this relates to their most viable fertile window.
Mhm.
There are two ways that an egg can fertilize. One is through natural insemination, where sperm is washed, it's processed, and it is essentially dumped on the eggs and let them swim together for an overnight date and we check them in the morning to see who got in and who didn't.
Mhm.
Versus ICSI, intracytoplasmic sperm injection, which is a procedure where we take a single sperm and inject one sperm into each egg. And this is really designed for people who have risks of poor or failed fertilization, although it's being far more widely used now across, I would say most patients have this done, even though by diagnosis they don't technically need it.
Got it. And then what would people expect in terms of the funnel from eggs that survive long enough for this window to be fertilized, whether by ICSI or conventional? What's the drop off that they should expect?
I think it's reasonable to expect that 80% of eggs are mature. So let's say you get 10 eggs, only 8 will be candidates for being fertilized because of their
Hmm.
maturation status. Of the 8, you would expect about 75% to fertilize.
Okay.
So I would expect out of 10 eggs, I would have 6 fertilized. Out of those fertilized eggs, which, by the way, the day after the eggs are collected, you know the fertilization. It's
Hmm.
about 16 hours or 18 hours after you do the fertilization event, can you determine the fertilization status. 4 to 5 days after the eggs are fertilized, they should form a blastocyst, which is the
Hmm.
stage at which you would freeze them, transfer them, biopsy them.
Hmm.
About out of your 10 eggs, I would expect 3 blastocysts on average. So that
Got
is
it.
the drop off. 10 eggs, 8 mature, 6 fertilized, 3 blastocysts. That's the textbook scenario.
Got it. And then what is a blastocyst? How is that different than an embryo?
Yeah, good question. A blastocyst really is the first differentiated embryo that is visible. An embryo prior to the blastocyst is really like a bunch of grapes. It's
Hmm.
thought to be 8 to 16 identically, or 20 or 30 identically, genetically identical cells. They just sort of budding, they divide 1 to 2, 2 to 4, 4 to 8, etc., etc. Once the embryo starts forming a blastocyst, you now have different types of cells. So the cells, not
Hmm.
only do they look different, they actually have different roles. You have cells now that are destined to become the placenta, and you have cells now that are destined to become the fetus. And that's what you have in a blastocyst. You have cells that are fetal destined and cells that surround it that are destined to become the placenta and involved in implantation in the uterus.
Got it. So yeah, can you talk to us about how the biopsy works? Does it harm the embryo? How many cells do you need? Does it come from the fetal DNA or does it come from that placental DNA?
Sure. Sure. Embryo biopsy or blastocyst biopsy, or more accurately stated, trophectoderm biopsy, which is the placental layer of the blastocyst, is becoming very commonplace now. And I really believe that if a biopsy is done well, that it has a minimal impact on the blastocyst. The biopsy really involves the removal of 3 to 5 cells on average from the trophectoderm, which makes up probably 60 to 70% of the cellularity of the total blastocyst. So let's say a blastocyst has 100 cells, 70 cells will be in the trophectoderm and 30 cells will be in the inner cell mass, which becomes the fetus. So if we're taking 2 or 3 to 5 cells from the embryo, we're really taking a very small percentage, 3 to 5% of the embryo, let's say, for analysis. And we're not taking the part from the blastocyst that becomes the fetus, we're taking the part that becomes the placenta. And there are plenty redundant cells there that are able to be lost without affecting the viability. But remember, what goes along with biopsy most times is freezing. So it's not
Hmm.
just the risks or the impact of the biopsy itself, it's the upcoming freezing and thawing or the vitrification and warming of that blastocyst that has to be considered part and parcel of the biopsy itself.
So, how exactly does the biopsy happen? Is it with a pipette? Is it the laser? How does it happen?
The biopsy happens by placing a blastocyst in a dish on a microscope that has pipettes on it that allows us to position and anchor the blastocyst so that we can use a laser to actually cut some of the cells off the blastocyst so we can pull them off into a pipette and get them into a tube for analysis ultimately.
Got it. Okay. And could you talk a little bit about now people are doing egg freezing for multiple reasons? Can you talk a little bit about is there anything known about the actual quality of the eggs and embryos that survive this whole process compared to the eggs and embryos that maybe would have met the traditional way at the same age?
Yeah. No, I really believe that vitrification, the breakthrough of egg vitrification, really has allowed us to, for the most part, freeze time for the eggs. There's no question that there's the potential for some damage or some loss to occur that would essentially not be a level playing field, fresh versus frozen. And the question always is how many eggs to freeze, since there is no technology yet to really establish whether an egg de facto can fertilize and make a blastocyst or not. We tend to err on getting more eggs than running out of eggs. But you could have 100 eggs that are not good. So we still are at the mercy of, without fertilizing an egg and challenging it to go to a blastocyst, we're at the mercy of the risk of low or poor fertilization that would result in low or poor blastocyst formation. With fresh eggs, there's probably slightly less of a risk of a poorer outcome, but certainly using vitrification with fresh oocytes has really allowed us to extend the reproductive age of women, has allowed us to allow women who may undergo some gonodotoxic treatments to still have children without, after they survive these trying treatments and toxic treatments
Chemotherapy, yeah.
therapy. It can allow XY individuals to potentially have babies. So there are many positive ramifications of the breakthrough of egg vitrification that go beyond just giving a woman reproductive freedom, which I think it has.
Yeah. So those 5 to 6 cells that are sampled, so those are sent off for genetic analysis. Can you talk a little bit about what excites you about whole genome sequencing for embryos?
Yeah, well, I mean, this is the area of most excitement for me, at least in the field, is the genetics and what can be done with those 3 to 5 cells. The technology is rapidly evolving, and especially with ORCID being able to do whole genome sequencing now on a representative number of cells from the embryo is remarkable. I truly believe it's going to be life changing with the type of information that we're going to be able to get from a single biopsy. I think arguably in the future it could be irresponsible to conceive without knowing what's in your hand before you play it, so to speak. What we know now and what we don't know really is what excites me, because of course it's a slippery slope and we have to do this with the utmost caution, with weigh-in from bioethicists, and just make sure we're going down the path of most caution and most potential benefit. Too much of a good thing is not a good thing, but I'm most excited about being able to do this responsibly. And again, the things we don't know about excite me too, because as I've gotten better perspective and better vantage points, as I've learned more about the potential of these technologies, it's excited me even more about what the future holds for procreation through our technologies.
Can you talk a little bit about how genetic testing has changed since the beginning of IVF and what the differences are and what types of information is available right now?
Its genetic testing has evolved unbelievably over the last several decades, and I think we're in the middle of a genetic revolution, if you will. So I think they're changing as we speak. But we've gone from whole chromosome level detection down to single gene level detection using easier approaches for the embryologist, which is unbelievable, because I can tell you when we did our first whole chromosome counting using fish, we had to do things as embryologists that we were never trained to do properly, to fix nuclei on cells and worry about overlapping nuclei and making calls that were very difficult to make, putting geneticists in tough positions. And we've gone from that, where there have been arguably several papers that have argued its utility, to getting to absolute definitive results that are irrefutable, clearly gone from shades of gray to pretty much black and white with resolution that we never had before. We've gone to versions of encyclopedias, down to not book chapters, but down to misspelled words in the volumes of encyclopedias.
Yeah, and it's basically requires basically the acceleration of technologies from so many different fields, from chemistry, from bioinformatics, for sequencing to get cheap enough, or the databases to get large enough. So it's really building on the backs of many different fields and many different giants.
No, it's absolutely, I think, one of the cornerstones of this breakthrough is the synergy between multiple professions and technologies to get to the place where you can actually do it in a cost effective way and have a meaningful outcome.
Yeah. So IVF is becoming, I would say, much more normalized than it was 20 years ago, 10 years ago, where there was a lot more stigma around it, taboo around it. It didn't work as well. So for couples that are considering doing IVF, not for infertility, but just because they want to have children later or they want to get results for their genetic screening, how do they weigh that decision between traditional conception versus IVF in terms of the quality of the egg, in terms of the quality of the sperm? Does it make sense to freeze now and use later? Or how do they make that decision? How can they start thinking about that in an intelligent way?
It's having starting a family is no simple decision. Having options in your family building is one of the luxuries that most people can't afford, but given what IVF can offer nowadays, I think it's something that we're not going to be able to afford not to do in the future, given the information that we can get before we commit to who's going to be born. There's no question in my mind that IVF is going to be the most common way to conceive in the future. Now, whether that's in a decade or two or three or five, I don't know. But there's no question in my mind, given the kind of information that we can derive from an embryo about the health of the individual to be born, it makes no sense for me to roll the dice and just hope I have a normal, healthy kid. Clearly, this one size does not fit all across our planet. But I'm speaking now in United States, in Western countries, in cosmopolitan cities where human beings have this luxury. It's going to go that way. I have no doubt.
Yeah. You talked a little bit about, hey, 900 eggs are lost every month. Is there anything that's known around the just the biology or the mechanics of which ones are lost versus which ones are able to be retrieved just from the egg retrieval, and then similarly which ones actually survive? Is there any way to compare, hey, this is the egg that would have been fertilized naturally and this is the quality of the egg or the embryo that was created in the lab?
No, unfortunately not. There's a highly complex selection process that goes on in the ovary during each menstrual cycle. And of
Mhm.
about 1,000 eggs that start this journey to recruitment and ovulation, only one makes it. And it
Mhm.
is not extremely well understood what makes one egg the egg and whether that egg is that much better than the egg next to it or two eggs down. But it involves a very complex feedback system with growth factors and differentiating factors that ultimately culminate in a single egg being ovulated. So we don't know when we get 10 eggs, which was that egg that was going to be the
Mhm.
chosen one. But we don't feel there isn't really evidence to show that out of those 10 mature eggs or the 8 mature eggs out of 10 that we got, that there's any sort of hierarchy in egg quality out of the mature ones. And to be quite honest, a lot of my research and current interests revolve around trying to develop an interrogation system for egg viability, because it would be quite helpful to help make decisions in family building.
Got it. So basically, just in terms of the science, it's not really well understood what the mechanism is for this is the egg that was ripened, and is it similarly not well understood for which sperm is the one that is able to fertilize the egg, or is there more known about
No,
the winning sperm?
no, there's nothing much known about the winning sperm or the winning egg, to be quite honest, other than they need to have certain prerequisites, i.e., be chromosomally normal, have certain physical constraints that allow them to meet, i.e., enough sperm with enough motility to get into the egg. But no, there is no way to differentiate or identify those.
So, what do you think the biggest misconception is for patients who are going through IVF today?
I think the biggest misconception is that patients think that IVF is a one shot deal. And IVF
Mhm.
should be viewed as a course of treatment. We're lucky if it works the first time. We try our hardest to get it to work the first time. But you need to set your expectations right, that it typically takes more than one shot to hit the bullseye. And you need to expect to do this more than once.
Got it. Thank you so much. This was such a exciting discussion about all things from eggs to sperm to embryos, and it was really a pleasure to host you. Thank you so
Thank
much.
you very much. Take care. Bye bye.